All right, everybody, welcome back to Ultrasound Grand Rounds this week. Pretty excited to be continuing on this year, and we are going to continue on with our topics that we're talking about. We did a little bit of shear wave elastography last week with Sean Gibson from University of Buffalo, and today we're going to continue on in that soft tissue theme. I was looking back at our channel, and we don't really have a ton of stuff about soft tissue, and so today we're going to dive into an introduction to soft tissue to really set the stage and set the groundwork for building in the next few weeks about some of the nuances about soft tissue ultrasound. And so with that being said, let's get going. But first, for those of you who are joining us on the YouTube channel, definitely be sure to hit that subscribe button, hit the like button if you like this video, share it with your friends. All those things really help us out to get the information that we're producing out into that algorithm and get it in front of people so that they can benefit from this as well. So go ahead and help us out there with that. But we're going to turn over to the slide deck and we're going to talk about some soft tissue ultrasound today. So, but let's talk a little bit about the context of a patient case. So this is a 28-year-old female. And this is like I typically do, a decently made up scenario, but it's based on a composite of patients that I've seen in my practice. And I think if you think back about it, some patients that you've seen in your practice as well. But let's imagine a 28-year-old female presenting to the ED with swelling, erythema, and pain to the mid-right forearm, right? And you can kind of, as you think about that, imagine that, kind of conjure that up in your mind of what that might look like. And that's going to lead us to a number of differential diagnoses. In fact, I've been spending some time with one of the residents that rotates with us on service recently, really going through how do you put together kind of that physician thought process, right? You go and see your patient, you collect a history, and then you come out and how do we present that as, as a trainee to the attending? And I mean, obviously that's important in this context as an academic facility, but when you're out on your own, right, you kind of do that mental presentation in your head. And we've been really hammering in about how that differential that's built off of what's going on with the patient clinically is the foundation then for all of our decision making and all of our testing that we're going to do after that. So if we think about this particular patient, the 28 female with swelling, erythema, pain to the arm, that's going to bring up a decent differential. Most of the time we're going to say, hey, this could be cellulitis, or this could be an abscess, or this could be some other dermatitis, and there's a whole long list of dermatitis etiologies that we can think through. But I think the big one that we want to talk about, with pain, swelling, and erythema is this an abscess and is this a cellulitis? And sometimes these are really, really self-evident. You look at it and you're like, I think this is, exactly one. Like if you got a hole in the skin with pus pouring out of it, I think that's probably pretty self-evident that this is an abscess, versus if it's flat and just tender and there's no fluxions to it, no crepitance to it, you could say, well, this is probably decently assumed to be just a simple cellulitis. However, there are those patients that are in between and it's like, I really don't know what is exactly causing this patient's symptoms. And so having another imaging modality to be able to identify and differentiate and figure out between all of these kind of what's going on can be really, really helpful. And this is where ultrasound kind of comes in and can be a huge game changer and help as we think through about how to manage these patients. And so with that said, let's talk briefly about the indications for ultrasound in the soft tissue arena. And then we'll go through and talk about the anatomy, sonographic anatomy, how we get our patient prepped, and then how we differentiate that cellulitis versus abscess. And that's going to be really the outline and the roadmap for today. So indications for soft tissue ultrasound. Basically, they have soft tissue, and there's something funny that you want to look at, which I guess is super reductionistic. But in our context today, the indications are pain, swelling, or erythema in a particular area on the soft tissue, right? And what this is going to allow us to do is get a dynamic assessment of that skin and soft tissue and see what is really going on underneath the skin. Like I don't have that ability with my two eyes to peel the skin layer back and see what's going on underneath. But with my ultrasound, I can come to the bedside and really peel that back and say, okay, here's what is going on, and here's now then what I need to do about that. So with that said, let's talk a little bit about anatomy. Right? We'll talk about the layers of the skin that we see, and then apply the ultrasound to that and see that we can really identify those different layers on the ultrasound and help us figure out where these lesions are at. So if you like a simple cartoon-like schematic, right? This is our the schematic of our skin, right? Skin and soft tissue. So the top layers are going to be your epidermis and your dermis, right? And those are going to be decently thin layers. And underneath that, we have a layer of varying thicknesses, depending on person to person or region in the body of that subcutaneous adipose tissue, or the subcutaneous fatty layer, right? Deep to the fatty layer, then you have a bright white fascia. Right, it's going to be a layer that separates the epidermis, the subcutaneous layer from the muscle layer. We're going to have that deep to the fascia, and then even deeper than that is generally going to be some bony structure, especially as we're talking about in the extremities. And so we can kind of think through this layered phenomenon, or this layered characterization of the skin, almost like you're looking at the layers of rock at a big canyon, right? And then we can start looking at the ultrasound and see some of those layers applied here. So just to kind of set our expectations, or kind of set our mind to what we're going to be looking at, this is basically a normal ultrasound of the soft tissue in the different layers that we talked about. And if we go over to this slide here, we can look at how you can really break those down and see the different layers that we talked about and their sonographic characteristics on this particular image, right? So at the very near field, you can see a thin layer, right? It's kind of that dense echo texture. And it's going to be the epidermis and the dermis, right? And then we go down a layer, you can see kind of that looser, more marbled appearance of tissue. That's going to be the subcutaneous layer, the subcutaneous fatty layer. Deep to that is going to be that hyperechoic bright white line, right? That's going to be our fascia. And then deep to that is the very coarsely striated layer called our muscle layer, essentially. And so I think if we kind of look through this and stare at this for a little bit, it's going to help us identify these as we go to our patients. And I think a couple characteristics that I want to point out, just to kind of reemphasize and highlight again, is going to be in that subcutaneous fatty layer. It has that mid-gray echogenicity, right? You can kind of see that it's not black, not white. It's just kind of that mid-gray, but it also has that very marbled appearance. So imagine, kind of look back at the pictures of a nice, beautiful slate of marble, right? All the architecture from the ancient period, or look at a marble countertop or something like that. You can see the rock, right, and those veins that kind of run through that, right? We're going to see that kind of an echo texture in the subcutaneous layer with just this tissue in between all the layers and the lobules of the adipose tissue kind of in that layer. And so this becomes really important, because as we look at this, we can say this is normal, and then as we make that inflamed, this echo texture, right, and this echogenicity are going to change, right? And we'll see that displayed in some images in upcoming slides as we get through this presentation. But that's really the picture of normal sonographic soft tissue anatomy that I really wanted to have you guys see and really kind of burn into your mind, because when we start doing things to the soft tissue, we're going to violate this picture. We're going to change this picture in some way to show us the image, or to give us the images of the pathology that we're going to look at. So with that said, let's move on to patient and machine prep. A couple things here kind of as we work through the actual facilitating getting the ultrasound done. We're going to want to select the transducer that's going to give us probably the highest resolution we can possibly get. That's going to be our linear transducers. It's going to be a high frequency transducer. That high frequency is going to translate into high resolution. And since all the tissue, or all the structures that we're looking at, are skin deep, and in the subcutaneous tissue, it's generally not going to be much more than 4 or 5 centimeters at total depth. The high frequency linear transducer can really be our ally, or a good tool to use here and give us that resolution that we want, because we really don't need the penetration depth, right? Now, that being said, some structures are going to be deep for various different reasons. And so if the structure is really approaching that 4 or 5 centimeter mark in depth, and you need to see it a little bit better or a little bit deeper, then you may need to transition over to that low frequency transducer to get the greater penetration out of that transducer, as opposed to the resolution that we would be provided by with the linear transducer. From a patient standpoint, you want to position the patient in whatever's comfortable to them. So it's going to be somewhat dependent on what you're scanning. It's going to be somewhat dependent on the patient. Usually they're sitting on the bed, right? So they're going to be some form of supine or semi-reclined. But if you can imagine if you have a big lesion on the back of the leg or something, you just roll them over on their stomach. There's no rule that says they have to be supine. You have to, contort them in some uncomfortable position. The more you are comfortable, and the more the patient is comfortable, the better the images are going to be and the better the scan's going to turn out, right? So that's the first thing. Position the patient in their position of comfort, primarily. Secondarily, position them in a position or in a place that you can be comfortable while scanning so you're not hurting yourself. And I guess as a brief aside, if you want more details on how to do that, go back to the YouTube channel. We have a lecture about the ergonomics of ultrasound and how to maximize that. Go back and check that one out. We did that one a little over a year ago. There's a pretty good lecture. But anyway, back to this here. Once you and the patient are in the position of comfort, then obviously you need to expose the area of concern. But unfortunately, given the nature of what we're scanning, this is oftentimes going to be something that's decently painful. And so we have to find ways of getting the scans that we need, applying the amount of appropriate probe pressure that we need to apply without causing undue and unnecessary pain. And so a couple techniques that I found to be helpful here is just being generous with the gel, right? This, you can call it whatever you want. I like to call it a standoff pad, but essentially if you apply a copious amount of gel to the patient's skin surface, you can almost glide that ultrasound transducer across that pad and really not apply a ton of pressure to the skin surface itself, making things a little bit more comfortable, right? So don't be stingy with your gel. Gel is decently cheap. Apply as much as you need, apply a little bit more than you need, and just glide that transducer through that gel pile so you aren't putting significant amount of pressure on your patient's skin. The other technique that can be helpful, especially when you're looking at distal extremities, can be using a water bath, right? So if they have some lesion on the fingers or on the feet or the toes or whatever, you can just fill up a bucket of water, immerse the structure in that water, and then the head of the transducer is watertight. I wouldn't submerge the transducer all the way down to the cord, but the head of the transducer is watertight, and so you can just set the transducer head just underneath the water surface, and then the water itself acts as a coupler, a sonographic coupler to allow the sound waves to approach the skin surface, and it works really, really well, right? And then in this situation, depending on your depth of water, you may not even need to make physical contact with the patient's finger here, because the water serves as its own standoff pad. So a couple different techniques that can be helpful as you work on trying to make the patient as comfortable as possible while you're doing your scan, right? Now, the final aspect of scanning technique to cover is this whole idea of orientation, right? So this is obviously me scanning my Achilles tendon, which is not going to be, for the skin and soft tissue purposes. It'd be more of an MSK application, but the same principles apply, right? When you do ultrasound, you want to do two orthogonal planes, or scan at two orthogonal planes. They say one view is no views and two views is one view. And I think I've seen enough things over the years with ultrasound and with other forms of radiography, particularly x-rays, where if you look at it in one plane, it looks a certain way, and when you look at it in another plane, it changes things just a touch, where you can see the orientation, both the x, y, and z axis. And so as you're scanning the soft tissue, you definitely want to scan in the long axis, and you want to scan in the short axis. You can call it sagittal, transverse, long and short, whatever you want, but you want to scan in those two different axes to get a full representation of what's going on with this particular structure that you're scanning, right? Now, we're going to follow the typical conventions of scanning, so we're going to put the probe indicator towards the patient's right-hand side, or the probe indicator towards the patient's head, so that we can reproducibly, generate this image, and then I can come back, the next day and create the same image using the same probe orientation. So with that said, that's kind of the initial overview of the normal skin anatomy, normal sonographic anatomy of the skin, and the patient and probe preparations. So what I'd like to do with the duration of our time, and we will go a little bit short today, we don't have to fill our whole time today, but what I'd like to do with the duration of our time is specifically focus in on the ideas of cellulitis and then the idea of abscess, and see how the ultrasound can really help us identify which process is going on, right? And how to differentiate the two when we look at the patient. Because as you remember, I can only see with my eyes skin deep. And if it's not apparent what is going on at the surface of the skin, then I'm going to need something else to go under the skin to help me identify if I have an abscess versus cellulitis. And so hopefully the rest of this discussion will be helpful for you as we kind of process through that. So we're going to start off with cellulitis, right? That's going to be the first thing to talk about. What does the ultrasound appearance of cellulitis look like, and how can we identify that as we do our scans at the bedside? So just starting off with a little bit of a clinical image. This is a picture that I pulled from Google. So Google cellulitis, you'll get a bunch of pictures. And so in this particular one, this is an example of, a patient who has, some erythema to the skin, right? This is going to be an example of simple cellulitis. But there's a lot of other things that can kind of masquerade as this. And sometimes depending on how much subcutaneous tissue you have, you can hide an abscess down there. So the question is there something that I need to drain, or is this something that simple antibiotics can detect or can affect, right? Now, as we get going on the ultrasound findings of cellulitis, I think it'd be helpful to review a little bit of what's going on from a pathophysiologic perspective, right? And so if you think about it, this is a picture of the inflammatory cascade, right? And as someone has cellulitis, they definitely have some degree of inflammation going on in that tissues. And I don't really want us to go through all the details of this cytokine here and that cytokine there, and it has this receptor here and that thing there. But all that to say, right? There's this idea, this pathophysiologic thing happening where you have a stimulus, right? Usually an invading pathogen that triggers a cascade of local and regional and distant hormones, right? To then bring all the inflammatory process to bear at that site. And so what you have is basically this cytokine cascade that's going to trigger ultimately a demarginization of these cells into the soft tissue to attack and fight whatever the offending agent is. And when that happens, you get this membrane separation of the capillary membrane, allowing leakage of basically plasma fluid into the tissues. In that process there, that capillary permeability, that leakage of fluid into the tissues is really going to be the bedrock of the findings that we're going to see sonographically as we look at these findings of inflammation. So if you back up kind of to my medical school days, they gave me this mnemonic or memory aid to talk about the different findings or characteristics of inflammation. And those are basically going to be a bunch of Latin terms with an Americanized English term that's kind of made to sound Latin-ish, right? So my kids are at school, they're studying Latin. This is kind of on the front of the mind in the Tabbut family. So here's a couple words to improve our vocabulary here, right? So the first one is going to be rubor, right? And this is the Latin term for redness, right? So one of the features, the clinical features of cellulitis and inflammation that you're going to see is this redness in the area, right? And that's going to be from that capillary dilation, right? So we have increased blood flow to the area. We have that in more blood kind of coming into that area, kind of giving that reddish colored appearance in the inflamed area of the skin, right? The second one, the second Latin term that we're going to talk about is tumor, right? And we think about tumor in the context of like some cancerous growth, but basically in the Latin, it just is going to mean swelling, right? And so one thing that we're going to notice as we go through our ultrasound findings and even our histologic findings or our clinical findings, in an area of inflammation, you have swelling, right? That's what this tumor is all about. And if you think about it, we have that capillary permeability that allows fluids to leak into the tissues. Those fluids are going to occupy some physical space. We're going to stretch the cells out, and spread them out a little bit. And we're going to have that swelling at a histological and at a gross pathological level, right? And so the first two findings, redness, swelling. The third Latin term that we want to talk about is calor, right? And this is a term which means heat, right? And so because we have all this fluid leakage, because we have this capillary dilation and increased blood flow in the area, we're going to experience some warmth to that tissue compared to surrounding areas, right? And so as we think about how you're taught to assess for for example, like a septic joint. They say, is it swollen? Is it red? Is it warm to the touch, right? Those are going to be all findings that we're going to point us towards this idea of some inflammation happening in this area, right? And the fourth term is this idea of dolor, right, which is going to be a Latin term that means pain. And so because of all this going on, because of all the inflammatory cells that are in the area, kind of irritating things, we're going to have some pain in the area, right? So if you take that, red angry spot on the skin and start pushing on it, it's going to hurt, right? It's going to cause some pain. And so this is the fourth thing, this fourth hallmark of inflammation that we can see. Well, maybe you won't see this one so much, but here our patients respond, in pain as we scan them, right? And the fifth one is going to be the Americanized English, term that we're going to make sound Latin, right? Move no more, right? It has to end with the or sound. So rubor, tumor, calor, dolor, move no more, which is basically designates when you have inflammation, you're going to have a lack of function, right? It's going to affect the function of the tissues that are inflamed. And so in the skin, it really doesn't really do a ton of, lack of function because it's not a dynamic tissue in the same way that maybe the heart is or the lungs are. But as you can imagine, right, if you inflame the heart or if you inflame the lungs, all of a sudden you're going to now have some cardiomyopathy, right? You may not have as strong of an ejection fraction as you had before. Or if you inflame the lungs, you're going to not be able to perfuse or exchange gases like you were before, and you're going to have some hypoxia, right? And that's what we get with pneumonia or ARDS. And so these are all examples of what happens as tissues get inflamed. And the one other thing that I'd like to add, just to kind of fill out not only the space on the slide, but also kind of what we're going to see is you have this fluid leakage, right? And we talked about this specifically in the context of tumor or the swelling, but I wanted to reemphasize it here because we're going to see this as we do our ultrasound, where we have all that fluid that leaks out of the capillaries in the subcutaneous tissue, and we're going to see that as fluid in the tissues, right? And so with that said, these are the pathophysiologic processes that are going on that represent inflammation. What we can see, and we're going to show this here in just a sec, is as we move over the image, the ultrasound image, we're going to see these different findings on the ultrasound image. And I'll show you a slide and just after we kind of go through them, and it compares the normal versus the abnormal. We can really see the effects of that inflammation, of that infection in the cellulitic patient on that ultrasound. So the first one here, the first finding is going to be an increase in the thickness of the skin and subcutaneous layer. So if you remember back at the beginning of the presentation, we showed those different layers. We showed the epidermis and dermis, we showed the subcutaneous layer, and we showed the fascia, we showed the muscle and the bone, right? And so what we're going to see as we scan this area, and then maybe not so much only as we scan this area, but as we scan past the area or around the area, is we're going to see the inflamed portion of the skin is going to be thickened, right? That subcutaneous layer, that marbled layer is going to be thicker than the rest of the surrounding tissue. And I encourage you, on the next time you actually go scan, normally we don't think about it. We just put the probe down, like, looks inflamed and there's no abscess there. And we don't look at the surrounding tissue. Go scan down to normal, scan into the abnormal, scan back up to normal, on the other side of things. And what you'll notice as you do that is you'll see that subcutaneous layer goes from a certain thickness, depending on where you're scanning and who you're scanning. And as you get to the inflamed part, it will thicken up a little bit. And as you go back to normal, it'll get thinner again. It'll kind of thin back down to the normal findings that you had on the first side of it. And so that's the first thing. And as you're scanning, take a look at that. You've passed over it a lot of times, I bet, but now that you know to look for it, you'll see it, right? You'll see that thickening in that subcutaneous layer. The second one is a change in the echogenicity, right? And this reflects all that fluid in the interstitial space, right? The swelling of the individual cells and the fluid around the cells. It's going to change the echogenicity. It's going to make it brighter. So we talked about the echogenicity of the subcutaneous layer being that kind of mid-gray marbled appearance, right? It's going to really change that from mid-gray to kind of a little bit brighter gray, right? It's going to brighten that up just a touch. And so again, as you are scanning along, scan to normal skin and then scan over the pathologic area and then scan back up to normal skin, you'll see it goes from kind of that darker mid-gray to a little bit more hyperechoic back down to the darker mid-gray, right? So echogenicity is number 2. The third one is a change in the differentiation of that marbled appearance. So we showed the image, we showed that very veiny, marbled appearance of the subcutaneous tissue, and we're gonna see that in normal. But as we make this tissue inflamed, as everything's kind of swollen and laden with all that fluid, we're gonna lose that differentiation of the marbling, right? And it's gonna become all more of a homogeneous appearing echotexture, like what we see here, right? It's decently homogeneous. You can see some lobules here, you can see some differentiation between those, but we don't have that like hyperechoic vein running through it. It's all just kind of that, a little bit brighter than mid-gray, just homogeneous, decently appearing echotexture. It looks more like a liver now than it did before it got inflamed, right? And the final thing that we're going to see, the fourth characteristic of cellulitis on the ultrasound is going to be edema in the tissues, right? And so this is where when I showed that picture of the river through the forest a couple slides ago with those 5 different characteristics of inflammation, this is what I'm referring to, right? So as you have that capillary membrane leakage, as you have that fluid going into the subcutaneous tissues, not all of it's intracellular, some of it's going to be interstitial, and we're going to see those little rivers of fluid throughout that subcutaneous layer. Now, an important thing to mention here before we move on is these findings are decently sensitive for cellulitis, but they are not necessarily specific for cellulitis, meaning someone who comes in with lymphedema will demonstrate similar symptoms, right? And the reason for this, not symptoms, but similar sonographic findings. The reason for this is a lot of these sonographic findings are secondary to the fluid shifts that happen in inflammation, right? I'm not seeing a bunch of macrophages here. I'm seeing the effects of fluid, like localized fluid in that area, right? I'm seeing that the thickening, those little rivers of fluid, the loss of the marbled echotexture, all that secondary to fluid. And so anything that's going to change that interstitial fluid is also going to give these types of appearances. So your CHF patient with bilateral lower extremity pitting edema is going to look similar. Your lymphedema patients are going to look similar. Your cellulitic patients are going to look similar. And this is where it does come down to a little bit of correlate clinically, because the story is going to have to drive how you interpret this study, right? So with that aside, this is an example of just normal tissue. So kind of going back, refreshing our memory, the top dense echotexture layer, the very, very, very top is going to be the skin and the epidermis and dermis, and then that marbled layer that is going to be the next couple centimeters is going to be the subcutaneous layer. You can see those, the hyperechoic veins kind of running through it, giving that marbled appearance. That bright white fascia then separates the subcutaneous layer from the muscle underneath. The muscle is going to be that very coarsely striated on the left-hand side, and kind of that starry night appearance on the right-hand side. And then obviously I don't have any bone in this one, but that's going to be the normal layers of this soft tissue ultrasound. So if we put these side by side, what we can see is the echogenicity of the tissue. And again, the gains are set a little bit different, so it's not adjusted to be a perfect correlation. But the echogenicity of the cellulitic side is going to be a little bit more relative to other structures there. It's going to be thickened, definitely looks thicker there. It's going to trade out some of those white veins, right? That marbled white veins with those dark black fluid, the fluid in the interstitial space. You can definitely see a huge difference between the normal here and the cellulitic side. A couple more images is just to kind of show things here. You may have some hyperemia as you have dilation of the blood vessels coursing through that area. And then finally here, this is just a profound amount of interstitial fluid that is going to be representative of this patient's cellulitis. So that's the overview of cellulitis, how you get from the normal sonographic anatomy to the cellulitic anatomy. With that said, what I'd like to do for the duration of our time here is then talk about abscess, right? And show some images of the abscess and how you kind of break down the anatomy of an abscess and show the difference between abscess and cellulitis, so that when we go back to the bedside, we can really use this as a tool to help us identify which one's going on, right? So kind of breaking down in the same pattern what's going on just from a gross histologic perspective. Obviously, you have your skin. This is image from the medical dictionary as referenced below. But you basically have your skin and subcutaneous layers, and then underneath that, you have that subcutaneous layer. And again, we're going to talk about this in the context of subcutaneous abscesses, but you can really apply some of these principles to intramuscular abscesses and things like that in other different places. But essentially, we have in the subcutaneous layer the necrotic core, right? They called it here they said in the label the pus, right? Essentially, all that inflammatory debris, all the necrotic cells, the evidence of the battle that is taking place in the subcutaneous layer is going to be in that core of the abscess. Now, surrounding that, you're going to have a bunch of inflamed tissue. So they call it the granulation tissue. I'll show you a picture in a little bit here with some kind of color overlays, but I like to call it the inflamed penumbra, right? Some other terms that you can use is kind of the phlegmonous portion of it. So the phlegmon is the inflamed stuff that's going to become necrotic, but is not yet necrotic, right? And then as we extend out kind of these different radiant spheres kind of moving out from the core, we get to eventually more normal tissue, right? The non-inflamed tissue. And so let's move on over to the ultrasound, and we can see how these findings can be replicated on our ultrasound machine, right? So the first thing here, here's the image. Here's an abscess. The first characteristic of an abscess on the ultrasound is basically this hypoechoic core, right? And so I've seen these over the course of the years that I've done this. I've seen this look a number of different ways, right? But generally, you see this core, right? This nucleus of inflamed tissues, and I've seen it range all the way from anechoic to decently isoechoic. It could be anywhere in there. But what you see in that core is generally something that's less echogenic than the surrounding structures. Generally, you see a complete loss of that architecture of the normal skin. It's just some lake of liquefied material, essentially. But it's going to be the hypoechoic core. That's going to be our characteristic number one. Characteristic number two is it tends to be decently ovoid. And I use this word very, very cautiously because I don't want you to say, well, it's not an oval, so it can't be an abscess. In fact, most abscesses kind of have, while they have this ovoid-like core, they can have different arms and tendricles and in different shapes depending on how much is inflamed and where you're at. And this is where I think ultrasound becomes really, really important, is it really helps us identify not just where is the thing emerging closest to the skin, but what's going on underneath the skin, right? The third characteristic is this idea of irregular borders, right? And so we'll talk in future weeks about cystic structures. And one of the things that you'll notice about cystic structures is they tend to have very smooth, well-demarcated borders. I mean, it's a cyst, right? That's the definition of a cyst. It's got this bordered thing and there's something in it, right? An abscess is not that, right? An abscess does not have that shell. An abscess is basically a lake of liquefied material that's kind of growing, right? So as more material gets inflamed, as more necrosis happens in the tissues around it, that lake grows. And so as you can imagine, right, there's nothing containing that or confining that except for the integrity of the tissue around it. And so it's going to have this very irregularly shaped borders, kind of these tendricles moving different places, right? And that's going to help differentiate us from other subcutaneous lesions, right? And then the final characteristic of an abscess is this idea of sonographic fluctuance. And that is when you apply a small amount of probe pressure, oftentimes you'll see movement inside that core that is not consistent with just normal displacement of tissues. Like if you were to put your ultrasound probe on normal skin, right, and compress it, right, you'll see that the architecture of that soft tissue is decently preserved all the way through the compression. It may just be squashed a little bit or flattened out a little bit, but the architecture stays the same. What you see with the abscess is because there's no architecture, because it's all liquefied, when you apply some pressure, it's just going to move out of the way, right? You'll see that movement or that sonographic fluctuance. And I'll show you a picture coming up here in a minute, but you can also look back on our YouTube channel this last week as one of our shorts. I posted a brief clip of that sonographic fluctuance just to show when you apply some probe pressure, you can see that sloshing of material inside that necrotic core. It's really going to help us identify that as an abscess as opposed to something else, right? So those are the 4 different characteristics of abscess. Let's put some color on this just to kind of help us see it. So move this over to the middle. Here's our abscess. The red here is that necrotic core. That's liquefied. There's not much we can do about that. That's just a bunch of inflammatory and cellular debris that's left there and just waiting to be released, right? Surrounding that, right, is what they call that granulation tissue. I call it that penumbra of like inflamed tissue that's probably in some degree of approaching, becoming liquefied, right? That phlegmonous changes surrounding that abscess. And then if we go a little further, here's the blue, we can definitely see those characteristics of the inflamed tissue relative to the uninflamed tissue. And in fact, I'm just going to back up here a minute, take that blue off. If you look, you can see that hyperechoic area that's just underneath that abscess. That's all the inflamed tissue that bears the characteristics of cellulitis that we just talked about a few minutes ago. Now, if you look in that zone surrounding that, we get back to that hypoechoic, kind of more marbleized texture of normal tissue, right? And so this is, I encourage you when you scan to scan above and below the lesion, including normal skin. This is what you're going to see. You're going to see that marbleized stuff turn into a thicker hyperechoic zone. And then if there's an abscess, you'll see more of that, phlegmonous necrotic area kind of in the center of that. And so that's going to be the anatomy of our abscess. And so looking at a couple different examples, here's one where you can see kind of that decently ovoid, but definitely irregular borders. The core is hypoechoic relative to the tissue around it. And you can even see those inflammatory changes in the tissue around it that are, be that hyperechoic, decently homogeneous architecture minus those rivers and lakes of fluid that are running through that area. The other thing that you may see is this idea of you may see just hyperemia, right? So because we have all that fluid that's not fluid, because we have all that increased flow, increased capillary permeability, we're going to have some extra flow kind of around that area. And so if you put color on, you may see a little bit more color there as opposed to other normal tissue. So making that live, you can kind of see that abscess and that hyperemia. Here's an example of that sonographic fluctuance. So as you apply a decent amount of probe pressure or a small amount of probe pressure, you're going to see just kind of some of that movement, that translational movement of that purulence inside the abscess. And I think this is a good example to take a pause and maybe go down a little bit of a rabbit trail here. One of the critiques of soft tissue ultrasound with specifically vis-a-vis abscess is this idea of, well, if I know there's an abscess there, why should I bother to scan it, right? Why should I bother to look at it? I know what I'm going to do. I'm just going to do it. I'm going to drain the thing, right? And there's a decent argument to be made there that if there's an obvious abscess, that from an evidence-based perspective, the ultrasound is not going to add anything when the outcome of what you're trying to add with the ultrasound is there an abscess there, right? And I have an article to point to published by Jen Marin where they basically broke things down into obviously cellulitis, obviously abscess, and we don't really know, right? Those 3 different cohorts. And ultrasound really had the most profound effect in the we don't really know category and really didn't change management much when the obviously we know sides of the arms, right? And I think that's an argument to be made, right? For those who desire to, maximize their efficiency, you can make that argument. The counter argument that I would make to this one is, well, when you go in, you don't know exactly what you're getting into, right? You don't know how deep this thing is, how loculated this thing is, or if it's just one small lake. And so the benefit of applying ultrasound here, and we can see it in this image, is how deep does the thing go, right? How big is it? And is it going in a trajectory that I'm not expecting, right? And so I've definitely utilized this principle over the years in my practice where I haven't maybe initially got purulence, but I know that where I made the incision is deep and just off to the left, right? And so I begin dissecting down in my incision deep into the left, and lo and behold, I get it, right? Or, hey, I expect this thing to be a pretty simple one, but wow, this really goes a lot deeper than I expected. Or the counter, like, man, I wonder how deep this goes. Oh, it's just one little pocket. If I just open that, express the purulent fluid, I'm done, right? So there's different ways you can apply that, and I haven't really seen a ton of literature that looks at some of those nuanced secondary findings. But I think there's a huge benefit of ultrasound in those particular places to look for kind of the secondary things that we want to know about abscess, not just is the thing there, right? So end of rabbit trail. Let's kind of get back to our slide. Here's another example of an abscess. I'll make that one go live, but you can just see a very soft or superficial subcutaneous lesion kind of in that area. Hypoechoic, seems ovoid, very, it's just one small pocket. We can easily get to that with a scalpel and some forceps and we're done, right? And so example of how ultrasound can help us out, just kind of not only just knowing that it's there, but kind of procedure planning is in the process. So with that said, the question then becomes, well, how good is this, right? Is there any literature that supports this idea of ultrasound to scan the skin and soft tissue? And I'll point you to two articles. There's obviously more written about it, but there's two specific ones I want to point you to. So this one was published 2005 by Chris Fox's team, and they were looking at the sensitivity specificity of your clinical exam versus your ultrasound. And they showed that your clinical exam is okay, but not great, right? Looking for skin and soft tissue infections. When you add the ultrasound to that, you profoundly improve the characteristics of your physical exam, right? And so if you're going to go into this saying physical exam only, 86, 70% sensitive specific respectively. If you add the ultrasound, you increase that to nearly 100% on your sensitivity and about 88% on your specificity, right? The next question is, does this change management? We talked a little bit about this before, but here's a study that was published by Vivek Tayal I don't think I wrote it down here, but this one was published about the same time, about almost 20 years ago now. But basically looks at, when they did the ultrasound, did the provider change what they're going to do based on the ultrasound that was performed, right? And what they found is that there was about a 56% change in management when you did an ultrasound on the patient. And this is where I mentioned that Jen Marin's study, they nuanced it a little bit into categories of did you know what was going on versus did you not know what was going on. And the 56 is a little bit of a bullish number when you have clear evidence of one versus the other. But when you get into that category of we're not entirely sure what exactly is going on, this is where the ultrasound can provide a huge benefit to helping you out and helping your patient out. So with that said, I want to do a little bit of a recap here. As we talk about skin and soft tissue ultrasound, we talked a little bit about the normal anatomy and the normal sonographic anatomy, kind of hit that a few different times over the course of the lecture, but use that as the basis to really help us identify the differentiation between the cellulitis versus abscess, right? And so cellulitis, there's those four characteristics of increased thickness, a little bit of an increased echogenicity, decreased tissue differentiation, the loss of that marbling, and then the presence of that subcutaneous edema. From an abscess, we talked about the characteristics of being hypoechoic, having the ovoid appearance that maybe has irregular borders, and then has that sonographic fluctuance to it as well. And so the key to remember is that you can oftentimes have the abscess with the cellulitic changes around it. And so as you're scanning your patients, definitely identify the abnormal area and then try to scan through and find the normal area to notice that differentiation. So with that being said, I think we'll wrap things up here and see, are there any questions to this content or things that we talked about today?